The brain responds differently to cannabis depending on how it enters the body. And understanding why this happens, it requires understanding some basic chemistry and neuroscience. Let's start with smoking. When cannabis is smoked, THC molecules enter the bloodstream through the lungs. The journey from lungs to brain takes seconds. Blood carries THC directly to the brain, where it begins interacting with cannabinoid receptors almost immediately. Effects typically appear within minutes and last 2 to 3 hours as the body metabolizes and eliminates the compound. Now, when cannabis is eaten, the process is fundamentally different. After digestion, THC travels through the intestinal wall into the bloodstream. But unlike inhaled THC, ingested substances pass through the liver before reaching general circulation. This is called first-pass metabolism. The liver contains enzymes that transform delta-9 THC into a different compound called 11-hydroxy THC. And here's where it gets interesting. This metabolite has distinct properties. Research indicates it crosses the blood-brain barrier more efficiently than delta-9 THC. It also appears to produce more intense psychoactive effects and remains in the system for longer periods. So when cannabis is consumed orally, 2 active compounds circulate simultaneously: the original delta-9 THC and the liver-created 11-hydroxy THC. This dual presence creates a qualitatively different experience than inhalation alone.
Let's talk about the endocannabinoid system. This exists naturally in the brain. You were born with it. It regulates memory formation, appetite, pain sensation, mood, motor coordination, and sleep. The brain produces its own cannabinoids, called endocannabinoids, which include anandamide and 2-AG. These bind to cannabinoid receptors throughout the nervous system. There are 2 primary receptor types. CB1 receptors concentrate in the brain, particularly in regions governing memory, decision-making, movement, coordination, and emotional processing. CB2 receptors appear mainly in immune system tissues. Now here's the key difference. Natural endocannabinoids release in small amounts at specific times and locations. They provide precise signaling. THC, by contrast, activates CB1 receptors throughout the entire brain simultaneously. It remains bound to receptors much longer than natural cannabinoids. So what does this actually look like in different parts of the brain? Let's go region by region.
In the hippocampus, THC disrupts short-term memory formation. Information enters awareness, but fails to consolidate properly into retrievable memories. This effect reverses when THC clears the system. Long-term memories remain intact. The prefrontal cortex handles planning, decision-making, impulse control, and time perception. THC impairs the ability to track time accurately. Minutes may feel like hours. Complex organizational tasks become difficult. Executive function decreases temporarily. Now, the amygdala processes fear and anxiety, and this is where things get really interesting. THC's effects here follow a biphasic pattern. At lower concentrations, amygdala activity decreases, reducing anxiety. At higher concentrations, activity can increase, potentially causing anxiety, paranoia, or panic. The response depends on dose and individual brain chemistry. Because oral consumption produces both delta-9 THC and the more potent 11-hydroxy THC, higher total cannabinoid concentrations become more likely. This increases the probability of crossing into higher dose territory where anxiety-inducing effects emerge. The nucleus accumbens functions as the brain's reward center. THC triggers dopamine release here, creating feelings of euphoria and enhancing sensory experiences. Food tastes more intense, music becomes more engaging, colors appear more vivid. With the more potent 11-hydroxy THC from edibles, dopamine effects can be stronger and more prolonged. The cerebellum coordinates movement. THC impairs this coordination, creating clumsiness and difficulty with fine motor tasks. Physical movement may feel effortful. With edibles, because effects last significantly longer, impairment extends for many hours rather than 2 to 3.
Let's talk about the endocannabinoid system. This exists naturally in the brain. You were born with it. It regulates memory formation, appetite, pain sensation, mood, motor coordination, and sleep. The brain produces its own cannabinoids, called endocannabinoids, which include anandamide and 2-AG. These bind to cannabinoid receptors throughout the nervous system. There are two primary receptor types. CB1 receptors concentrate in the brain, particularly in regions governing memory, decision-making, movement, coordination, and emotional processing. CB2 receptors appear mainly in immune system tissues. Now here's the key difference. Natural endocannabinoids release in small amounts at specific times and locations. They provide precise signaling. THC, by contrast, activates CB1 receptors throughout the entire brain simultaneously. It remains bound to receptors much longer than natural cannabinoids. So what does this actually look like in different parts of the brain? Let's go region by region. From a respiratory perspective, avoiding smoke inhalation eliminates exposure to carbon monoxide, tar, carcinogens, bronchial irritants, and particulate matter. Regular cannabis smoking associates with chronic bronchitis, increased respiratory infections, and lung inflammation. Oral consumption eliminates these respiratory risks entirely. However, oral consumption presents different challenges. The difficulty controlling dose increases risk of overwhelming psychological experiences. The longer duration means impairment extends for many hours. Accidental consumption by children or pets becomes possible when cannabis products resemble regular food. The more intense, extended effects increase likelihood of triggering anxiety or, in vulnerable individuals, transient psychotic symptoms. For individuals with genetic predisposition to schizophrenia or other psychotic disorders, high-dose THC exposure can trigger or worsen symptoms. The higher cannabinoid concentrations more common with edibles increase this risk. Cannabis cannot cause fatal overdose through respiratory depression. The brainstem, which controls breathing and heart rate, contains very few cannabinoid receptors. THC does not suppress these vital functions the way opioids do. No lethal dose has been established in humans. However, psychological distress can become severe. Emergency room visits related to cannabis have increased in areas where it is legal, with edibles representing a significant proportion. People experience severe anxiety, panic attacks, rapid heart rate, extreme paranoia, disorientation, and nausea. While not in physiological danger from the THC itself, the psychological experience can be genuinely overwhelming. The physical symptoms, particularly elevated heart rate and nausea, combined with altered time perception and inability to escape the experience, create intense distress. Medical treatment focuses on reassurance, calm environment, and supportive care while waiting for effects to diminish naturally. Cannabis hyperemesis syndrome represents a serious condition associated with chronic, heavy use. It causes cyclical episodes of severe nausea and vomiting. The mechanism involves cannabinoid receptor dysfunction from chronic overstimulation. The only effective treatment is complete cessation of cannabis use. Continued use after developing the syndrome leads to recurring and worsening episodes. With regular use, the brain adapts through several mechanisms. Cannabinoid receptor density changes. The number of CB1 receptors can decrease, a process called downregulation. Natural endocannabinoid production may decline as the brain adjusts to external cannabinoid presence. These adaptations mean the same dose produces diminishing effects over time. This is tolerance. When regular use stops, the brain begins recalibrating. Receptor density gradually normalizes. Natural endocannabinoid production increases. Neurotransmitter systems restore their baseline function. This process follows a predictable timeline. In the first week after stopping, the brain is recalibrating from chronic cannabinoid receptor activation. Sleep architecture may be disrupted. Appetite can change, mood may fluctuate, irritability sometimes increases. These reflect the nervous system adjusting to managing stress and regulation without external cannabinoids. By 2 to 3 weeks, receptor density begins normalizing. Sleep quality typically improves, appetite regulation stabilizes, mood becomes more consistent. Cognitive clarity increases as the hippocampus and prefrontal cortex resume normal functioning without THC interference. By 1 to 3 months, most neurochemical changes have reversed.
CB1 receptor density returns to baseline, natural endocannabinoid production normalizes, cognitive function, including memory formation and executive function, fully restores. The brain has reestablished its natural regulatory balance.
The changes cannabis creates in the brain are significant but largely reversible. Neuroplasticity, the brain's capacity to adapt and change throughout life, allows recovery. Receptors normalize, neurotransmitter production restores. Neural pathways that weaken during regular use can strengthen again. This reversibility represents evidence-based hope. The adaptations that develop with regular use can reverse with sustained abstinence. The timeline varies by individual, depending on duration and frequency of prior use, genetics, and overall brain health. But the fundamental capacity for recovery exists. Understanding the mechanism, why eating cannabis creates different effects than smoking it, provides insight into drug delivery systems generally. The same molecule can produce different experiences depending on how it enters the body. Liver metabolism, individual genetics, and absorption patterns shape the neurological impact as much as the substance itself. The key distinction is this: oral cannabis is not simply stronger, it is neurologically different because of liver transformation. 2 active compounds instead of 1. Higher potency metabolite, longer duration, less predictable onset. These factors combine to create an experience that differs qualitatively, not just quantitatively, from inhalation. This understanding matters for anyone considering cannabis use, anyone supporting someone who uses, or anyone working in healthcare, education, or policy. The delivery method fundamentally changes what the brain experiences, and what the brain experiences determines both acute effects and long-term adaptation.
The brain's endocannabinoid system evolved to support specific regulatory functions. When external cannabinoids flood this system, especially the more potent 11-hydroxy THC from oral consumption, effects extend beyond what natural signaling would produce. The intensity, duration, and unpredictability reflect this mismatch between evolutionary design and modern consumption patterns. Recovery is possible because the brain is designed to adapt. The same neuroplasticity that allows adaptation to chronic cannabinoid exposure allows recovery when exposure stops. Receptor systems recalibrate, natural production resumes, cognitive function returns. If this helped, subscribe for real talk on mental health.